Hello and welcome. As a professional in the monitoring, evaluation, accountability, and learning space, I get asked one question all the time. Did our program truly make a difference? Well, today we're diving into the gold standard for answering that very question, randomized controlled trials, or RCTs. Stick with me, and I promise you'll walk away with a solid, practical understanding of this incredibly powerful tool.
Think about it. Was it our intervention that actually created the change we're seeing, or was it something else entirely? In the complex world we work in, finding a credible answer is, frankly, our biggest challenge. And the most rigorous method we have for nailing down that answer with real confidence is the randomized controlled trial.
So, to give you the full picture, we're going to break this down into 4 key parts. First, we'll get on the same page and define exactly what an RCT is. Then, we'll unpack the real magic behind randomization. After that, we'll get practical and look at how these are actually implemented in the field. And finally, we'll have an honest chat about the realities of using them, the good, the bad, and the challenging.
Okay, so let's start at square one. Before we can even think about the how or the why, we need to be absolutely crystal clear on what an RCT actually is. Let's build that foundation.
Here's the textbook definition, but let's break it down. An RCT is all about taking an eligible population, and then, and this word is everything, randomly assigning them into at least 2 groups. You've got your treatment group, they get the program, the new seeds, the cash transfer, whatever it is you're doing, and then you have your control group, who doesn't. Because the only real difference between these 2 groups is that random coin toss at the beginning, we can confidently say that any differences we see at the end are because of our program. It's that simple and honestly that powerful.
Now, this is a really important point and a common trip-up, so let's be clear. Random assignment is not the same thing as random sampling. Random sampling is how we pick a representative group of people from a much larger population to be in our study in the first place. Random assignment is what we do next. It's how we sort that sample of people into the treatment and control groups. You know, a good RCT is probably going to use both, but they are 2 very different steps with 2 very different jobs.
So what is this magic of randomization I keep talking about? Why is it the absolute engine that makes this whole methodology work? Well, it all boils down to one thing: creating a truly fair comparison right from the get-go.
Okay, this table here really shows you what's going on. Look at these 2 groups, a treatment and a control, pulled from the same population. When your sample size is tiny, like say 10 people, you can see some pretty big differences between them. But watch what happens as that sample size gets bigger, to 100, and then to 1,000. Those differences just shrink away until the groups are statistically the same. So with a large enough sample, random assignment basically ensures you have 2 groups that are, on average, identical mirror images of each other.
And this is the beautiful result. We get what's called balance. The groups are balanced on all the things we can see and measure. Things like age, income, education level. But here's the really cool part. They're also balanced on the things we can't see. Those tricky, unobservable traits like someone's personal motivation or their natural ability or how much risk they're willing to take. And that means the control group becomes our perfect counterfactual. It tells us exactly what would have happened to our treatment group if they'd never gotten the program at all.
You know, beyond all the statistics, there's a really practical and ethical argument for this too. When a program has limited spots, meaning we have more people who need it than we can actually serve, a lottery is often the most transparent and fair way to decide who gets in. It takes politics and favoritism right out of the equation and gives everyone an equal shot.
All right, so we've covered the why. Now it's time for the how. Let's shift gears from the theory and look at what it actually takes to get an RCT up and running in the real world.
While every study is a bit different, the process generally follows these 6 core steps. First, you collect that baseline data to see where everyone is starting from. Second, you do the random assignment. Third, the intervention gets rolled out to the treatment group. Fourth, and this is so important, you monitor constantly to make sure the program is being delivered right and that the control group isn't accidentally getting involved. Fifth, you collect your endline data from both groups. And finally, number 6, you analyze the difference to see what your impact really was.
One of the first big decisions you have to make is your unit of randomization. You could do a simple RCT where you randomize individuals or maybe households. But honestly, in our line of work, we very often use a cluster RCT. This is where we randomize entire groups or clusters, like whole schools or entire villages or clinics. It's often just more practical for how programs are delivered, and it's a great way to prevent spillover effects, which is when your control group starts getting influenced by their neighbors who are in the program.
Let's make this real with an example from a rural electrification program in India.
What I love about this one is that they didn't just have one treatment group, they had two. One group of villages got a subsidy to get hooked up to electricity. A second group got that same subsidy plus some training. And the third group was the control. This multi-arm design lets you ask a much smarter question, not just did it work, but which version of our program worked better.
Okay, so as much as I've been singing their praises, RCTs are not a magic bullet. It is absolutely essential for us as practitioners to have a balanced, realistic view. So let's get into the good, the bad, and the genuinely challenging parts of using them in the field.
On the plus side, their number one advantage is that they give you the clearest possible story about cause and effect. The analysis is often a simple comparison of averages, which is pretty easy to explain to donors and policymakers, and like we said, it's a fair way to allocate resources. But the limitations are very real. RCTs can be incredibly expensive and can take years. There can be real ethical questions about withholding a program from a control group, and sometimes the results just don't travel well. We call this low external validity. What works in a city in Kenya might not work at all in a rural village in Afghanistan.
When you're out in the field, you have to be vigilant because things can and do go wrong. You might have low take-up, where hardly anyone in your treatment group actually participates. You can have contamination, where the control group gets a piece of the program somehow. People can drop out of your study, that's called attrition, and if too many do, it can totally bias your results. Sometimes field staff don't follow the randomization protocol, and if your sample size is too small, your study will be underpowered, which means you could miss a real impact, even if it's actually there.
So let's bring it all back home. Where do RCTs fit into our broader MEL framework? Well, they serve two functions brilliantly. For accountability, the A in MEL, they give our donors and stakeholders the strongest possible proof that our program had an impact. And for learning, the L, the findings are pure gold. They don't just tell us if a program works, they can help us understand how and why, giving us incredible insights for adapting and improving our work.
All right, as we wrap up, if you take nothing else away from this, let it be these four things. 1. RCTs are the gold standard for proving causality because of random assignment. 2. That randomization creates balanced, identical groups from the start, which lets us isolate the program's true impact. 3. Pulling one off is a serious, multi-step process that requires a ton of care. And 4. They are an incredibly powerful tool, but we always have to be mindful of their real-world limitations and challenges.
I want to leave you with this final thought, because it really gets to the heart of it. A good RCT isn't just some final exam for a project. When you do it right, it forces this amazing collaboration between the research team and the program team. And that partnership doesn't just produce a better evaluation, it almost always results in a smarter, more effective program in the first place.
Thank you so much for joining me for this deep dive into randomized controlled trials. I really hope you found it practical and insightful. If you want to keep building your skills, please go ahead and subscribe for more advanced tutorials on impact evaluation and everything MEL. I'll see you in the next one.